So thank you very much, everybody. Welcome to our International Tumor Board with the American Board Certified Doctors for Egypt. Thank you, as always, for our case presentation and or event organizers between Dr. Manar Hamid and Karim from ABCDE. I appreciate the presence of our colleagues from pathology as well as from hematology oncology. We have here in the US, Dr. Robert Emmons from University of Louisville, as well as Dr. Sameh Gaballah from Moffitt Cancer Institute in Florida. We will have the first case presented by Dr. Hamid. Please, Dr. Hamid, go ahead.
Hi, nice to meet you all again. I'll start with case number 1. So this is a 64-year-old male patient who initially presented with left eye redness, blurred vision since September 2021. The patient sought ophthalmology assessment, and they ordered the pre and post contrast MRI orbit that showed mildly enhancing lesion at the site of the superior rectus muscle that measured about 3.3 in 2.4 centimeters. The rest of the globe and the lacrimal gland and the rest of the eye muscles all were normal. Ophthalmoscopic examination at that time showed diminished visual acuity of both eyes. And there was also bilateral cataract. So the patient did the surgical excision of the mass, and post-operative pathology was normal, just fibrofatty tissue with benign lymphoid infiltration, no atypia nor malignancy. And so the patient continued to follow up with ophthalmology till September 2023, where the symptoms recurred again. Non-contrast MRI orbit showed at the site of the initial mass there was recurrence that measured about 28 millimeters. And the conclusion that it's possible to be a orbital pseudotumor or hematoma and to much less extent lymphoma for correlation. So the patient again did the mass excision, and post-operative pathology was the dense small lymphocytic infiltration. Then he was referred to the oncology center for further workup and management. The first thing that was done was the revision of pathology and immunohistochemistry that was positive for CD20, focal positive for CD23, CD10 was negative, BCL2 was positive, and BCL6 was non-specific. Ki67 was only 10%. CD5 was not available, so was not done, and the diagnosis was suggestive of SLL/CLL. So the patient continued the workup of SLL. The CBC was completely normal, no lymphocytosis, no cytopenia. LDH was mostly elevated. Bone marrow assessment was normal cellular, no deposits, and the echo was normal. The patient didn't do screening intrathecal because he was intermediate risk. Yes, he was 64-year-old and the LDH was elevated, but the performance was okay. And the stage, we're not sure if it was stage 3 or 4. There was no other sites of extranodal involvement, and the kidney and adrenal involvement were free. So density assessment showed, besides the mass that is related to the left superior rectus muscle, there was nodularity and thickening related to the lower abdominal aorta and its bifurcation, forming mass-like thickening that extended to the right common iliac artery, query localized the retroperitoneal fibrosis, and the radiology conclusion suggested that it might be orbital pseudotumor plus retroperitoneal fibrosis that is suggestive of IgG4-related fibroinflammatory disorder. This is the image of the eye mass. As you can see, there is difference in density between both eyes. And this is also the eye mass. So before we ask our pathology fellow to comment, I have never heard of this IgG4 disease before, so I made a small search about it. It turned out lesion, the etiology is unknown, and it has the characteristic histopathology. Any symptom you can possibly imagine, but most commonly it appears in the pancreas, causing type 1 autoimmune pancreatitis. And as this case, it could be also in the retroperitoneal cavity, causing retroperitoneal fibrosis, or it could affect the lacrimal gland, causing IgG4 related adenitis. So there is a very long list of the diseases that can be caused by IgG4 or can be related to IgG4 disease. And this is not even the complete list. So to diagnose it, we have to incorporate serology with imaging, with histopathology. The IgG4 level may be elevated. It's usually elevated, but it is not specific. And the cutoff value is 135. There might be also low C3 and C4 in cases of renal involvement. And you have to take a biopsy that has the characteristic finding. I think Dr. Nermeen would be better in describing it. And there's also
Dr. Manor, I've lost the sound. I don't know if anybody else can hear her.
She's disconnected, Mo.
Yeah, no, I can't hear.
Manor, if you can mute and unmute, or maybe try to re-enter, but at the same time, I was wondering if Dr. Nermeen from pathology is with us.
Yes, I'm here.
Oh,
Alright,
welcome. Yes, you're disguised under a Zoom user, so
I don't
wasn't
know
sure.
what happened. I don't know what happened to my account. It's very
Yeah.
strange. I will change it later. Okay.
So I think Dr. Manor is having a little difficulty with
Yeah.
yeah.
Mm.
Do you have slides to share with us until Dr. Manor can
Yes,
join?
sure. I will
Can you hear me
share my
now?
screen.
Yes.
So maybe Dr. Manar will connect. Sorry.
Okay.
Yeah, I have 2 more slides, then I will
Sounds
switch
good.
to you, Dr.
Okay.
Nermeen.
Okay.
So what is the last thing you heard from me?
It was the Japanese
Yeah.
slide, but
Okay.
you have also you might have to share the screen again.
Can you see it now?
Yes. Yes.
Great. So the Japanese criteria, just 1 second, it's still loading. Okay. And there is also the Mayo Clinic criteria, which in addition to the histopathology and imaging, there is also the response to steroid therapy as a criteria for diagnosis. So to conclude, IgG is usually elevated, but it's not sensitive nor specific. And radiology alone can't differentiate and can diagnose, and we should exclude malignancy before calling it IgG4 disease. And in the end, if it is IgG4, it's treated with a steroid or rituximab. And so, Dr. Nermeen, how are you?
Fine. Thank you very much.
Okay, I will unshare now.
Okay.
Okay.
So I will share my screen. So can you see my screen now?
Yes.
Yes.
Okay, so the biopsy taken from the orbital mesh showed the dense infiltration with a small lymphocytes. Okay, you can see everything is blue. Okay, very dense blue. Small cells. Okay. These cells were strong diffuse positive for CD20. CD3 was positive only in scattered background T cells that here are negative. BCL2 is a strong diffuse positive, and this what can confirm here that this is a neoplastic process, because BCL2 is usually positive in T cells or interfollicular cells. Okay, so when you see it diffuse positive, this is more with malignancy. Ki-67 was very low, maybe 5 to 10%, with some areas of condensed Ki-67. Like they look like the pseudo follicles of the SLL or the proliferating centers. CD23 was focal positive in the cell. Cyclin D1 was negative. We did also BCL6 and CD10, they were both negative. We didn't have CD5 at that time. So for us, this is a straightforward case of a small SLL, small lymphocytic chronic lymphocytic leukemia. Okay, so it's nice to raise the possibility of IgG4. For IgG4 first, it's not a common entity here in Egypt. I studied in Japan for 2 years, so it was very, very common there. They are interested in the IgG4 diseases, and I think this entity actually came from Asian countries. Number one, we should see a very excess number, very, very big number of plasma cells. And we stain these cells for something called IgG4. So the clear cut for diagnosing IgG4 diseases is not well established yet in the literature. Some people say you must see more than 10 IgG4 plasma cells per high power field. Others say the population of IgG4 should be more than 40%. Others say 30%. Anyway, even the pathological report can say definite for plasma cell for IgG4 disease, related disease, or possible, or sometimes we are not sure about it. Serum IgG4 can help us if it's elevated. What's nice about IgG4 disease is that they melt under corticosteroids. They respond very nice to corticosteroids. But what changed everything here was the BCL2. It's strong diffuse positive. This doesn't happen with a reactive process or an IgG4 related disease or something. So from pathological point of view, this is an SLL-CLL case.
Okay, so Dr. Nermeen, why it can't be marginal zone lymphoma since it is negative CD10 and
Because it is CD23 positive.
it's focal positive, so
But a marginal zone is not positive. Unless it's a remaining germinal center. The lymphocytes themselves are positive for CD23.
okay.
Marginal zone also gives more follicular pattern. This was not seen here in this case. And you can see only something that looks like tail areas, but not the follicular pattern or the nodular pattern of the marginal zone.
Okay, thank you.
Thank you very much. If you want to be more sure, we can do CD5, but for me, CD23 here was enough.
Before we discuss the clinical aspect, I wanted to hear what Dr. Alquran would like to say on pathology as well.
Yeah. Can you hear me?
Yeah.
Yes, we
Yeah.
can.
Okay, thank you. Actually, I was going to make the same point. This is an excellent question. Anytime we're dealing with a lymphocytic infiltrate near the orbit, like this is just similar to any like an extranodal site close to a mucosal site. I would think my first priority would be to rule out marginal zone lymphoma, extranodal marginal zone lymphoma of the mold type. And I think in this case, and I'm sorry, like I cannot see the, the picture is not very clear, but were there any like pseudo proliferation centers with para-immunoblasts and immunoblasts and pro-lymphocytes? Because that's
Yes,
like what
actually,
would be
but
required.
yeah, but they are
Yeah.
not. Yeah, I'm with you. The
Yeah.
picture is not
So-
that much nice, but we can even the Ki-67 highlighted the proliferating centers, but it's not seen here in this picture.
Yeah, so I think,
sorry
and the
for that.
other thing is this, the CD20 is brighter than I would like to see
Yeah.
in small lymphocytic lymphoma.
But
So
I have seen many
this case
cases
has,
of I have seen many cases of CLL with a strong CD20 positivity. And I know it should be
Yeah,
them,
so-
but I have seen it before.
yeah, so without CD5, we cannot really make the diagnosis with confidence
Exactly.
because, the bone marrow was negative. Again, when you think of an extranodal site next to the orbit, most likely it's going to be a marginal zone, extranodal marginal zone lymphoma of the mold type. The other comment, so I think CD5 is crucial in this case. The other
Yeah.
comment, as far as the BCL2, BCL2, there's no doubt this is neoplastic, but
Mhm.
BCL2 in the realm of hematopathology, it's only like it wouldn't help us differentiate the subtype of lymphoma. It can only differentiate between follicular hyperplasia and follicular lymphoma.
Exactly. It's a marker for more to tell us about it's malignant or not.
Yeah.
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 But it's positive in all small cell lymphomas and many of the different large cell lymphomas.
Yeah,
also.
so yeah, like many, normal T cells can have it, marginal
Yeah.
zone,
But the diffuse pattern gives us an idea this is not a reactive process.
yeah.
Okay. So also I will recommend here CD5 actually, but it was not available in our lab in that time.
So any questions regarding pathology before we discuss it from the clinical perspective? So it sounds like CD5 would be helpful. No other question. Okay. Dr. Gabala, if we look at this, we have a periocular mass with this disease. It's either a CLL/SLL or a marginal zone. Where would you stand in regards to your decision?
Yeah, no, so thank you, Dr. Higazi. So, when Dr. Manar was presenting the case, the first thing, as Dr. Alcaran was saying, that comes on the differential is marginal zone lymphoma. This is a very commonly involved site of like a malt lymphoma in the orbit. So clinically speaking, before even looking at the pathology, my number one differential would be either a marginal zone lymphoma, and maybe the other thing that could also present this way is a mantle cell lymphoma. They could also sometimes, present with extranodal sites involving the orbits. However, mantle cell lymphoma, clinically speaking, usually would present with other sites of disease, not just the orbits. So more than 90% you'll see it involving like the bone marrow. You'll probably have, lymphadenopathy elsewhere. But, isolated orbital masses, these are typically marginal zone lymphoma. The other thing is these marginal zone lymphomas in the extranodal in the orbit very commonly would be bilateral. So you could see them on both sides of the orbit. I agree in terms of the pathology. It's very crucial, to do a CD5 here, because typically what you'll see in a typical marginal zone lymphoma is you'll have monoclonal B cells, positive for CD20, but then negative for CD5 and CD10. And sometimes they would report it, the pathologist would just report it as non-Hodgkin's, like an indolent non-Hodgkin's lymphoma with a non-specific phenotype, CD5 negative, CD10 negative. That's the other way that sometimes, that gets presented, and they'll say, The differential can include marginal zone lymphoma or lymphoplasmacytic lymphoma. But clinically speaking, this is very suspicious for marginal. The FISH studies, we usually would do here FISH studies as well, just make sure it's 11-14 negative, that this is not mantle cell. But again, clinically speaking, in this specific case, it's probably not mantle cell. And again, the cyclin D1 was also negative by immunohistochemistry. So this is, I have very, very low suspicion that it's a mantle cell. So in terms of staging, commonly you'll see those as isolated in the orbits. Bone marrow biopsy is crucial. So just for staging purposes, and this situation was negative. We typically would do a PET scan just to see if there's any other nodal sites, but I think the CT scan here is probably enough. There's no adenopathy that was seen elsewhere. I don't know what to make of the retroperitoneal fibrosis that they're seeing. And this is certainly not something that I would call, IgG4. IgG4 disease, you'll typically, they're not going to be small lymphocytes. You're going to see mostly plasma cells looking like cells, and they're typically positive for IgG4. Usually the IgG4 would also be elevated in the serum. But clinically speaking, I wouldn't do any further workup. I think this is a marginal zone lymphoma just based on the clinical presentation. So how do we manage it? Most of the time, this is just localized to the orbits. Radiation would be the standard. Now, I don't know, you would just have to see, if the radiation oncologist, they are, experienced enough with, radiation to the orbits, but the standard of care for this is really radiation. And you could do consolidation with 4 weekly doses of rituximab, and that's optional. Now, if the radiation oncologists, they don't commonly do this, and there's going to be a risk they're going to affect the orbits or the optic nerve or something, then I would just do rituximab. But the standard of care treatment for this would be radiation, as long as the radiation oncologist is experienced with this. You don't want to damage the cornea or the optic nerve or anything like that. So that's what I would recommend.
What if the surgical excision was complete? They cleared out all what they could get their hands on.
So didn't it recur again?
Yeah.
Okay,
After
so this
second
was a
excision,
got it. I'm sorry, I missed that
Yeah.
part. So, Dr. Munir, is Dr. Muhammad still here to weigh in as well? Muhammad Ibrahim?
I'm not sure.
Oh, Dr. Ibrahim, would you like to chime in on your impression?
No.
Okay. I wanted to get somebody from Egypt and one from the US. So, Dr. Emmons,
Yeah, several quick
differ?
questions.
Yeah.
The first one is, as marginal zone lymphomas closely adherent with exocrine glands, like in this case, a tear gland, can be associated with chronic inflammatory states like autoimmunity, including Sjogren's disease. Was there any evidence that this patient had antecedent dry eyes, dry mouth, or anything else going for Sjogren's disease?
No. His lacrimal gland was normal and functioning.
And there was nothing to suggest inflammation of the lacrimal glands separate from the lymphoma?
No.
Gotcha. I would certainly agree with marginal zone being the most likely explanation. It is a little worrisome that this seems to be acting more aggressively locally, and that is a little atypical for marginal zone, which tends to be a more bland growth and doesn't, this, as I understand it from your presentation, grew back fairly rapidly after it was resected the first time, correct?
After about 1 year and 7 months.
Oh, 1 year and 7 months it took. Okay.
And
But there was no
then
other
after
sign.
second resection, there is still residual after the second resection.
I see. Yeah, so it
And
does.
now the eye is totally blind, unfortunately.
I see. So you mean there's no symptoms currently?
No, no,
Oh,
he's
wait,
totally blind,
oh,
left eye.
the patient went blind with this mess?
Yeah.
Oh no.
Oh, that suggests that this is not just simple marginal zone lymphoma. So is the blindness because of invasion of the orbit or damage to the optic nerve, or what exactly happened to cause the blindness?
Is it, Dr. Manar, is it surgical related, the blindness?
I think, well, I will share again the radiology. Just
No, like when did the blindness
one
occur?
second.
Like after the surgery or what happened? Because typically this wouldn't really cause blindness.
If you can see it, the mass is likely suffocating the optic nerve, you know? It's like it's replacing it and surrounding it.
So what, the
So
blindness just happened like over time, or was it after the surgery or what?
when the patient came to us, he was already blind in his left eye
And that was before the surgery?
after the second resection. No, that was after the surgery.
Oh,
Okay, so
okay.
he
And it
came
wasn't,
to you as a second opinion?
What?
I'm sorry, so
He came because the pathology of the was showing dense lymphocytic infiltrate. So he came for further revision of the pathology and further workup.
So was there an attempt on the initial surgery to completely resect this as opposed to simply biopsy it? Is that what happened? And is that what maybe damaged the optic nerve? Is that what I'm understanding?
Well, the intent was to resect it, but unfortunately it wasn't completely resected. And I'm not sure of the details of the surgery because I don't have the records of the ophthalmology unit. But
yeah, Dr. Manar, did the
this is the
patient,
situation now.
yeah. No, but did the patient describe like what happened? Was the vision just gradually going away, or was it just suddenly after the surgery, or did he just like or that was not,
I can't hear you very well. Can you?
Yeah, you hear me?
I can hear you well.
No, no.
We're having a hard time hearing you, Dr.
Um,
Hamid.
Can you hear me now?
Yes.
Can you hear me?
Yes.
Yes.
Okay, please, can you repeat the question, Dr. Gabala?
Yeah. Do you know like wait, so when he came to you, like what when from the history, was the blindness just like the visual acuity, was it going down slowly, or was it, did it happen rapid? Was it, post-operative? Like what exactly happened to this guy?
Okay, when he came to ophthalmology in 2021, the visual acuity of the left eye was 6/24. Okay, and then over time now he's just blind in the left eye. So I think gradually would be the answer.
So it was like a slow, gradual process.
Yeah.
It looks like his right eye wasn't that great anyway either, but better.
Yeah, it had cataract and the visual acuity is 6/12, but that
Yeah.
was at 21. I don't know now how is the right eye visual acuity,
So
but he can't see up till now with the right eye.
So, Dr. Monar, as you can hear from Dr. Kabala and Dr. Emmons, is the concern here is the malignancy really invading into the optic nerve the reason, or was this part of the surgical resection that led to the loss of the vision And the way that the patient would describe their visual acuity changes is typically would be clear if it's surgical related or it's progressive, slow, gradual process. But that's unfortunate, but it makes the radiation oncologist's job easier, at least now that the vision is gone in this eye, in terms of how careful you have to be with close proximity to the globe. And that's
Yeah,
about it.
Yeah, and the other thing, Manar, is I would get like an MRI of the orbit on both sides because, just to the CT scan is not very sensitive. It would show up if something is really big, but I would definitely do like an MRI so that because again, typically those can be very commonly bilateral. So you could start with one side and then the other side would show up. So if you're seeing something on the other side on the MRI, you might preemptively, treated. It sounds like this guy was just, waiting too long and maybe, this should have maybe just like been done sooner. But I would definitely get an MRI of the orbits. This is yeah, usually we do like a contrast,
yeah,
MRI.
yeah. He refused. He refused at that time. I don't know why. But
Yeah, yeah.
I think we can repeat it again. He did it in September 23, so it's like
Okay.
9
Yeah, and
months.
you could do
I
it
think it
after the
was
radiation. You could just do it after the radiation and just to again look at the response and everything, but just to also look at the other side.
don't need to take a biopsy from the retroperitoneal mass.
So the retro, I mean, you don't have the images to take a look at, right?
No, I don't.
I mean, what one thing you could do is just, do a PET scan and see if it's lighting up. And if there's any concern that there's a more aggressive pathology, high uptake, then yeah, certainly you could biopsy it if it's a mass. But I don't know, they're just talking about like haziness and stranding and these are things that can sometimes be non-specific. But if there is a mass in there, I would do a PET scan and a biopsy, yes.
Yeah, and if it is positive, then you better give the systemic treatment better than just radiation to the eye.
Yeah, I think the I mean, yes, you could do, systemic treatments, I agree. And you could also, by the way, you could do consolidation systemic treatment anyway after the radiation. Particularly if you get, if you think this guy might not follow up, well, and we don't want it to go to the other side. Um, but again, the purpose really for the biopsy here is just make sure there's no aggressive, component to this. Because again, typically those would be slow growing lymphomas. They would just, be slow growing, but that doesn't mean that they cannot transform. I mean, I've certainly seen, before where these indolent lymphomas can transform to an aggressive lymphoma. So if you do a PET scan and there's high activity there, I would definitely, biopsy it to make sure. Now, do you have to treat it with rituximab? I mean, if it's indolent, you don't have to. But again, if you do the radiation, you can consider rituximab afterwards. That would decrease the incidence of local recurrence as well as recurrence on the other side.
Okay, great. So can I continue now?
Sure.
So the patient unfortunately was tested positive for TB in March 24 and started the rifampicin plus INH. So I have a few questions for you, Dr. Sana. Is it feasible to administer NTB treatment while the patient still having active disease and give so monoclonal antibodies, rituximab or obino or BCL2 or BTK inhibitor? Is that safe or should we wait till the patient clears
I
the
mean,
TB first?
so I had a patient before with like, florid pulmonary tuberculosis, but then he had an aggressive diffuse large B-cell lymphoma. So what we did was, just go ahead and treat both. We treated the tuberculosis, and then at the same time, he was getting his chemotherapy with anti-CD20 and everything. However, in a situation where you have an indolent lymphoma, You don't have to start right away with the anti-CD20. You could finish the tuberculosis treatment, maybe just have him do the radiation. But again, just do that PET scan to make sure it's not an aggressive pathology. Now, if you do the PET scan and you do a biopsy and there's concern that this is an aggressive lymphoma, then no, then you would have to do, like R-CHOP with the anti-tuberculosis treatment at the same time. So just kind of, it's always a risk and benefit. You have to balance things out. But to
Okay.
answer your question, yes, you
So,
can do it. Can do it, yes. If you have to, you can.
okay. So we want to talk about SLL and CLL a little bit since you are in the committee that puts the NCCN guidelines. So now we have bertobrutinib recently approved after progression or intolerance to BTK inhibitor. So now, which do you prefer to give bertobrutinib post covalent BTK or switch to venetoclax?
So, the current approval, at least, at this time is pirtobrutinib is approved after failure of a BTK inhibitor and a BCL2 inhibitor, meaning that the patient would have failed, ibrutinib, acalabrutinib, Zanu, and then a BCL2 inhibitor, and then you could use pirtobrutinib. Now, here's the thing. So suppose, you treated this patient as if he has SLL. The treatments will work great with marginal zone lymphoma as well, because BTK inhibitors, are great options for marginal zone lymphomas, and it's approved in the relapse setting. I have a trial here, using it in the first line. But the question is, is that what's needed? First of all, you're going to get like financial toxicity because, they're going to go on a BTK inhibitor indefinitely, whereas the radiation and anti-CD20s are time limited and obviously much less expensive. But to answer your question, pirtobrutinib, it's used in CLL in a very small fraction of patients that are, failing both. So it's not a huge population, but it is available. Also, CAR T was recently approved as well, Lysocell for CLL. So there's more and more options. But again, it's a very small subset of patients that are failing both the BCL2 and a BTK.
So is Lysocell as successful in CLL as it is in diffuse large B and other aggressive lymphomas?
No. So the CLL is, data with Lysocell. The CR rate was about 20%, and the responses were not very durable in those who had less than CRs. So it's not as successful in CLL compared to, say, mantle, follicular, or diffuse large B cell. And the unmet need is not as huge because we also have pirtobrutinib, which has much less toxicity, is much more convenient compared to Lysocell. But having another option is great.
Okay, so what about the combination of ibrutinib plus venetoclax? When we just look at it, we see counting both the toxicities of ibrutinib and the toxicities of venetoclax.
Yeah.
Although the trial, the GLOW trial,
Correct.
it showed that the toxicity rate in this arm, the experimental arm, was more or less similar to the other arm, which was the chlorambucil obinutuzumab. So it's a little bit surprising for me because I haven't seen patients taking this combination. So I was wondering, from your experience, how is that combination working? Is that very toxic as it seems, or is it tolerable?
No, it's definitely not very toxic. And, so here's the thing. So, and again, we could probably spend like an hour talking about this, but so the question is, time-limited therapy versus endless therapy. So with BTK inhibitors, you have endless therapy. And then, with the CLL14 study, you had time-limited therapy with venetoclax, obinutuzumab. But the problem is, it's not very convenient. The patients have to go back and forth. There's an infusion. The patients need to come to an infusion center. So the question is, the GLOW study came to look at a time-limited option that is all oral. combining ibrutinib and venetoclax. It can, it can be very safely combined. You do get more, cytopenias, from clinical experience, but that is not, too bad. It's certainly very manageable. And ongoing is the CLL-17 study going on, which is looking at ibrutinib venetoclax, time limited, versus obinutuzumab venetoclax, time limited, versus just an endless ibrutinib. And to answer the question about which is the best strategy here, but in terms of toxicity, no, the combination is not too toxic. Obviously, you do get some of the cardiovascular issues with the ibrutinib, like the AFib issues, the hypertension, the bleeding problems. But certainly, it's not it's not extremely toxic. It's very well tolerated, and I've certainly used BTK inhibitors and venetoclax and many instances, including, even mantle cell lymphomas that are hard to control with other approaches. So it's certainly very doable.
Okay,
I'd like to pause and
Okay,
go
yeah, a
back
few more
briefly to
questions.
just how you knew this was TB. What was the basis for making that diagnosis in this patient?
Well, our chest fellows diagnosed it, and they ordered the quantiferon test, and also his CT showed apical fibrosis that suggestive strongly of TB, chronic TB.
The reason I bring it up is because we've been trying to figure out why he lost his vision. And patients with advancing TB can get ocular tuberculosis, which can cause severe damage to the eye. Is there any evidence that his vision loss may have been related to ocular TB?
I'm not sure. I don't know.
Okay.
I wonder if that would have shown.
But I think if he's taking the TB treatment, I think it would cross to the eye, even if he has TB in the eye, right?
Yes,
I'm
sir.
not sure. I mean, non-caseating granulomatous are the classic thing one sees associated with those lesions. But again, the lesion that you've described in the back of the eye that seems more like marginal zone lymphoma may not be the lesion that caused the blindness. There's various forms, various ways tuberculosis can attack the eye, including uveitis, which is the most common, and certain other types of damage to the eye. Certainly immunocompromised patients who have lymphoma are more at risk of things like this, and we would place them at even higher risk for hematogenous spread with rituximab. So it's an important question as to whether there might be any contribution of this.
Yeah.
Yeah, that's an interesting thought. I'm looking here at thank you so much, Dr. Evans, for that link. So it looks like, you could get like an extra ocular muscle involvement with ocular TB. But then, I mean, the question is, could the TB be, causing this? I don't know if it would give you like a pseudotumor in the orbit.
We didn't, pathology specifically didn't describe case-eating granulomas or the kind of classic pathology one would typically associate with TB in the mass that was described. That really did look like a aberrant BCL2 expressing B cell population, which is more consistent with a clonal mass. So that is probably not that. But as everybody's pointed out, marginal zone lymphoma of the orbit shouldn't cause blindness, and it shouldn't cause severe damage to the eye. And even if it grew into a mass, it might cause proptosis. But even
Yeah,
then,
but if it is SLL,
sorry.
If it was a small synthetic lymphoma, could it be aggressive and cause blindness?
It'll be the same thing. It's also in there. But obviously, if there's uveitis and whatever, the eye would be very painful. Was this guy having any pain?
No.
No. Yeah, it's. I'm not really sure what happened with this vision thing, but it's certainly something that we would not be expecting.
Okay, thank you for this discussion. I have just a couple of more questions about this case. So, in general, like the cases of Richter transformation, since we are talking about the SLL and CLL, So we all know the regimens, the combination of anthracycline-based chemotherapy plus anti-CD20, and we all know that it is not very effective. The best survival was gained with R-CHOP. What do you prefer to use in your cases who develop Richter transformation?
Yeah, so I could, you know, so you're gonna, so there's no one standard regimen. I mean, commonly we would use, our EPOC or R-CHOP, but the outcomes are different. So if you have someone presenting with, concurrent diagnosis of, CLL and Richter's, these typically actually do not too bad, very similar to diffuse large B-cell lymphoma. The problem is those who have, had CLL, they've had multiple treatments before, and now they develop Richter's. Those patients don't respond well to chemotherapy, and they typically don't do great. The responses even to CAR T and are suboptimal. And it's an area of unmet need. I mean, there's some data with with pirtobrutinib that looks encouraging. There's some bispecific data that looks okay, but in clinical practice, these are the cases that we would always struggle with in clinic, and I'd be interested to see what everybody else does for these patients. But it's an area of unmet need.
Yeah.
What do you use, Dr. Hamid? What do you use in Egypt for Richter's transformation?
We use either R-CHOP or R-dose-adjusted EBOC. Yeah, and if the patient reaches CR, you can do allogenic afterwards.
Yeah.
Right.
We
Have
just
you
like
seen
Dr.
cases?
Gabala said. Go ahead.
Yeah, go on.
Yeah, just like Dr. Gabala said, there is no standard. Every institution has their own. R-CHOP has been used here historically quite a bit. They're not all the same, and unfortunately they're also small in number, so the presentations are far in between that we have cases with the Richter's transformation, which is not a bad thing for patients, but giving the how high is the incidence of CLL in general compared to the Richter's transformation is a small presence. Now, it is always an area, also an unfortunate area in clinical trials where when you are dealing with aggressive lymphomas, you will see that Richter's is sometimes singled out from those clinical trials as well. So you have data on small number of patients and not really agreed upon standard of care. I don't know what Dr. Emmons, if you would like to weigh in on how you would treat Richter's.
Yeah, I think like most of these unagreed aggressive lymphomas that have bad outcomes, the immunologic therapies are assuming a higher mantle. So, we're seeing clinical trials emphasize bringing things like CAR T earlier into the course of therapy, especially for young patients with aggressive disease like this. So I suspect that will be what will emerge as sort of the dominant thing to do with these patients who have bad outcomes with combination chemotherapy in general.
Yeah,
Dr.
and
Gabala?
also immune checkpoint inhibitors like Nivo and Pembro. Did they improve the outcome or?
So I've used it again in a couple of patients. It's a hit or miss. I mean, some of my colleagues had some luck. I personally have had very disappointing results. So it's yeah.
Yeah, that's why I say again, I think the field is kind of moving away from chemotherapy-based approaches for these very aggressive types of lymphoma and more to the immunologic approaches earlier in the course rather than considering them third, fourth, and fifth line because of beating up on the patients and bad outcomes because of immunologic complications and other issues that the patients won't be able to tolerate once it's given later in the course. And as we see, the more we study these various forms of BiTE and CAR T therapies, the earlier they're given, often the better the outcome overall for the patients.
But what about sequencing, like giving CAR T and followed by BiTE? Because already in myeloma, it is known that if you give BiTE after CAR-T, or if you give CAR-T after BiTE, the response might not be as expected. Is it also applied in lymphoma?
I think it's an immune system thing rather than a disease. So it's a T cell usage or exhaustion related question, and that applies in even in the aggressive malignancies, even in the acute lymphoblastic leukemias. The question comes, okay, if we use Blincyto and then we now have CAR-T, is that going to make the CAR-T outcomes worse? Same as in myeloma. Myeloma is maybe significantly shown in the use of any BCMA targeted or bispecific therapy prior to using BCMA CARs. The outcomes in those BCMA CARs is very poor. We currently don't use bispecific antibodies in the CLL itself, but in the Richter's transformation, I think it's going to fall into the same category of an aggressive large B-cell lymphoma, and then you might be able to eat your way in getting bispecifics. But if the patient is in shape for CAR-T, you might want to get them in earlier, just like Dr. Emmons was saying.
Maybe in the future we might test the T cells work, the T cell function before.
Well, that's an excellent point, because really the reality of T cell therapy moving forward, given the recognition of how diseased and disordered the immune system is in most of these patients, by the time they come for collection and production into CAR-T, or as we try to harness them with BiTE and other therapies, has recommended that we back up and ask ourselves how we get a better assay of understanding how the immune system can be improved to improve cellular therapy. In that regard, there's a very exciting bit of work that's come out of Herb Weissman's lab from the West Coast that showed that depleting myeloid-biased hematopoietic stem cells rejuvenates the aged immune system in mice. If this result pans out in humans to prove that decreasing the myeloid bias of the aging immune system, which predisposes it potentially to infections and cancer both, improves cancer surveillance and the quality of T cells for CAR-T therapies, it will be a very big paradigm shift in the way we look at the quality of T cells for these various production techniques.
Very interesting.
I'll send that link in the notes.
Yeah, thank you. So in Richter transformation, it's kind of different if the disease is clonally related or it is not clonally related. So what tests do you do to differentiate between them?
Is Dr. Alquran still here who can help us chime in that in clonal relation? I have an idea, but I want to hear what he would say. Dr. Alquran, the question is, how can we correlate the clones of Richter's to the original CLL disease?
Yeah, and I don't think it would. I mean, Dr. Hegazi, we've had cases where we did that. I mean, through sequencing and looking for that can be. But actually, I was in a discussion recently. It was in the workshop, the most recent one we had at MD Anderson, and they've had in specifically with Richter transformation, they've shown that there are some clones that may not be necessarily clonally related to the previous one, but I'm just trying, what's the goal for this question? How would that change your treatment?
Because if the disease is clonally related, we proceed allogenic after attaining CR by chemoimmunotherapy. If it is clonally unrelated, we can follow up after giving chemoimmuno if the patient in CR. We may delay allogenic transplant if the disease is clonally unrelated.
Yeah, so this is not something we do routinely on every case, but we've, anytime, in diseases where expect transformation, say Richter transformation with CLL. I mean, that's not something we do routinely, but if there is a question about the diagnosis, Like we know, we had a case that, we're going to present in our next tumor board. It was a marginal zone lymphoma, or it is, with increased proportion of large cells. And by the way, back to the discussion, this may not be the case, in this patient, but not all multiple lymphomas are, low grade or good. Even like the gastric multiple lymphomas, 10% of these can be more aggressive than usual. And, they can have a proportion of large cells. It will not be large cell transformation, but they would have larger cells present there. But in this case, for the B cells, this can be done through sequencing, and you can identify, you would have to compare the original, disease or tumor to the subsequent one if there was a transformation, and through the sequencing, they can show that they are similar. This can be done, one of the techniques that we're using right now by clonoSEQ and, other methods to use assess B cell clonality can also achieve that.
So if sequencing is a little bit expensive or not available, are there any similar tests to differentiate? Or,
unfortunately not, because looking at light chains, that's one method, but that's not necessarily indicate that it's the same. But that's one way that you can use, but it is not necessarily indicating it's coming from the same process.
okay, thank you. So one final question with this case. So we see this expression of CLL with expanded proliferation center or accelerated CLL, where the proliferation center are expanded or fused together. Is the pro-lymphocytes, where the pre-lymphocytes percentage is like from 10 to 55. So if we see a patient on treatment already and he's having now this accelerated CLL, is that an indication to change the line of treatment or treat it as if it is Richter transformation?
So that's so that's what we used to call pro-lymphocytic transformation. So now they have this other term, and pathology could obviously weigh in. But if this is like a pro-lymphocytic transformation, we don't typically jump to like a Richter style treatment. A lot of times they would respond to CLL like therapy. Like, for example, if someone is on a BTK inhibitor and then they have this transformation, sometimes they do very well with venetoclax, with the with a anti-CD20, but it's not, this would not be diffuse large B-cell lymphoma. It's still a high risk situation, but it's not a Richter's.
Yeah, so from us, like that's exactly, it's a kind of like you are watching the lymphoma in the process of transformation. So yeah, it is not, but you will see features like increased, even before this term was adopted, we've always had cases where when we see cases where we have increased proportion of larger cells, increased Ki-67, we would call these in transformation. So this is just to keep, an eye on these patients, and and it indicates that the disease is not going to be clinically or it's going to be clinically more aggressive than the usual or the garden variety CLL. But as Dr. Gawala said, it's not a large B-cell lymphoma of BCL.
Okay, this is like the MRD thing when the patient in CR and he's MRD positive, so he's not in relapse, but we need to watch him.
Your voice is cutting in and out, Dr. Hamid.
Okay, I was saying that this reminds me of the MRD situation when the patient is in CR, but he is MRD positive. He is at the high risk of relapse, but he's not actually not relapsing. So we just have to watch and wait carefully.
It sort of depends on the disease, you know. It's a nice analogy, but it depends, right? So if you're MRD positive and you're talking about ALL is different from an MRD positive and you're talking about CLL versus myeloma. But I think in this
Yeah.
setting, you know that you're going to progress, and changing therapy might be useful even if the patient even if the patient did have a response early on, the patient is in the process of progression.
Okay. Okay. Do we have time for the next case?
I'm afraid we should push it to next month.
Okay.
Inshallah,
Sure.
we can discuss it. This was a small case with an excellent discussion. I truly appreciate bringing it up, and I do feel like we learn a lot from even a case like this that is, you know, limited lymphoma. Still, we can learn a lot from it. I appreciate your time in putting it together, Dr. Hamid, as well as Dr. Mujahid from pathology. Appreciate our panel, both from the US and from Egypt. And I look forward to the next case to discuss next month. We will have an email to discuss about, you know, best weekend on a Sunday afternoon that we can regroup, inshallah. Thank you very much, everybody, and have a great rest of the day.
Okay,
Thank
thank you.
you.
Thank you. Thank you.
Thank you so much.
السلام عليكم. لا 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 بالعكس والله she's